Hello, and welcome to In Service of Health, brought to you by the Public Health Accreditation Board. This is the podcast that brings healthcare and public health leaders together to inspire new thinking for healthier populations. In this episode, I was thrilled to sit down with Dr. Alen Voskanian, Chief Operating Officer for Cedars-Sinai Medical Network. Dr. Voskanian is a board-certified physician in family medicine, hospice, and palliative medicine, and an accomplished author. He is a former innovation advisor for the Center for Medicare and Medicaid Innovation and assistant professor of clinical medicine at UCLA. Ellen and I sit down to talk about clinical operations, leadership, and how to bring and sustain empathy and compassion in healthcare and public health. The opinions expressed by Dr. Voskanian are his own and do not represent those of his employer. I hope you enjoy the episode. Dr. Voskanian, it is so great to have you on the show today. Thank you for joining us.
Thank you so much for inviting me. I'm excited.
Absolutely, so am I. I like to, let's just jump right in. I like to ask all of our guests to start off with just telling us a little bit about what motivates you to do this work.
Wow, it's a very deep question. I think it's really initially when I went into healthcare, I was motivated by my childhood experience of seeing my mom overcome breast cancer, and the care she received by her care team really impressed me as a young kid, and I wanted to be able to make that difference. So, what motivates me now to do that work is really tied into helping people, but helping people who are not really savvy of our healthcare system, people who are underserved, and people who are not getting possibly the best care. I've really found that I have a special interest in helping people who have been marginalized in the past. So that motivates me to make healthcare better for everybody.
Well, thank you for sharing that personal story, and I know it resonates with a lot of us who are in healthcare or public health, just wanting to make it a little bit better, a little bit easier for others. So one of the goals of these conversations, this podcast, is to really think about not just healthcare and healthcare delivery, but also public health,
Yeah.
and how they both kind of work together. So why specifically is public health important to you, and should it be, or is it important to society?
Yeah. I've been fascinated by that. And when I was getting my MBA, I had a chance to travel to India to learn about their healthcare system. And since then, I've traveled with my business school to a couple of different countries, including Japan, South Korea, also Spain and Portugal. And throughout these international kind of trips focused on healthcare, one thing that became very obvious to me is that health and well-being of people, of communities, really is dependent on public health and the infrastructure that we set up for people to be healthy. I feel like in United States, our view of healthcare is very medicalized and very much focused on treating an illness once people get sick. And it's really not about going to the root cause and addressing some of those issues that lead to diseases, chronic diseases such as diabetes or hypertension, which have a lot of morbidity associated with them. But when I was in Japan, I was so impressed by a couple of things that address public health. One of them is that a lot of elderly folks were not feeling isolated. They were walking to these community centers and hanging out with other folks, often singing karaoke, cooking food together. And one thing I noticed when I was visiting a community center is that it was really up on a steep hill. And most of us were having a challenge getting up to that community center. But then I noticed that the community members who were using that facility, who were in their 70s, some were in their 80s, were just walking up that hill to go to that community center. So that highlighted two public health initiatives right there. That one of them being addressing isolation that's so common in our elderly. And then the second one is exercise. And how do we make exercise part of our normal routine?
I love what you're saying there. There's been conversations around the epidemic of loneliness and kind of isolation in the elderly for sure, but also many individuals just we're so often socially isolated from others. But I also love what you talked about, which is that built environment, something that we talk about in public health very often. It sounds like I'm envisioning folks kind of walking every day to this center, and you don't even realize that it's exercise, but in
Yeah.
fact it is. So I love what you shared there, and also thinking about internationally, are there other examples from other countries that we can leverage to improve health outcomes in the United States? So you've just had an amazing, varied career, and you've worked at the intersection of operations, patient care. You've worked in underserved communities. You've thought really hard about community impact. Talk to us a bit about like what's the thread that ties all of these things together, and how do you work as an operator, like promoting operational efficiency and supporting a hospital's bottom line, but that's at the same time really prioritizing caring for communities.
Yeah. You know, I feel like there is a thread, even though when I look at my resume or my LinkedIn profile, I see that there's a lot of different things that I've done. But the thread initially started with that deep desire to help people. And early in my career, it was really focused on patients with HIV and AIDS. And I felt that I was making a difference because uh, most of the folks were facing this life-threatening illness. They were ostracized, and there was this deep sense of addressing suffering amongst patients who were not getting the care that they deserved. So really found that field very fulfilling. And then as HIV and AIDS became more kind of a chronic illness, I had a moment of reflection because I was feeling a little bit burnt out. And this is in early 2000s when burnout was not really a term that we were using. But upon that reflection, I realized things that led to my burnout were related to some of the operational challenges that exist in healthcare, some of the bureaucracy, some of those day in, day out annoyances that I refer to pebbles in our shoes.
Mm,
Sometimes, like dealing with them for many days back to back, end up kind of uh, taking away the joy that exists in healthcare, the joy that drew so many of us to go in healthcare. So when I was in that moment of reflection and a pivot point in my career, I realized what I really enjoyed was end of life care. So I became board certified in hospice and palliative care. And again, now reflecting back, it's because I felt that there was a lot of suffering in that period of life when patients and families are facing end of life crisis, and I wanted to help alleviate some of those suffering that exist. But throughout all those moments, I realized that the healthcare system is really I mean, I know it's cliche and we always say it's broken, but it is broken and it has so many opportunities for improvement. And I wanted to be involved in improving it. So that's when I went to business school. I started working in operations, got very interested in all the science around how to improve operations in terms of Six Sigma, operational efficiency, lean methodologies. And I thought if I could combine those kind of operational improvements, which are very kind of engineering based, with my kind of the humanity of healthcare, I feel like that's where the magic can happen, when we can kind of combine those two things. Because I've often seen people who really focus on lean and Six Sigma, not really realizing that healthcare is a human business and it's
Yeah.
a work that involves humans. They fail miserably. And also, I've seen the other way around, when you only focus on just running a clinic without focusing on how do you make it operationally sound, financially feasible. That's not sustainable either. So that's kind of what drew me to operations. I really love operations because I see so much opportunities. So many opportunities that can not only help our clinicians, but also our patients. So I think as a physician, one-on-one, I was helping like the patients I would see in a day or in a week. But now in my role as a chief operating officer, I feel like my impact is a lot larger.
It certainly is. I would agree. And you've just there's so many nuggets in what you just talked about. Let's go back for a moment and let's get specific about those pebbles in the shoe. And you talked about, the joy coming out of the profession. And I would say, both healthcare delivery, and also frontline public health workers, people working in health related kind of frontline service related fields are also experiencing this burnout. What Let's get specific about those pebbles. What
Right.
are the pebbles, and what can we do to get the pebbles out of our shoes?
Yeah. I mean, if we think about a patient journey, if it's in a clinic or in public health setting, just from the time that someone wants to receive care, when you call a clinic or call any community center anywhere to get care, often the phone doesn't get answered. And
Mhm.
often there's a long wait on the phone. And imagine you're not even feeling well. So it's a frustrating experience for the patient. And that also translates into the clinician, because when that patient finally comes in for their visit, the first few minutes, they want to really make sure that the doctor or the nurse or the clinician knows how frustrating the experience was. So if the phones are not working well, or if the wait is long when the patient has arrived, the first few minutes of the visit is going to be spent by listening to the patient, either apologizing or becoming defensive, but it's already setting up that clinician for confrontation. And then most clinicians try to get through it, they ignore it, but imagine you see 20, 30 patients a day, and every single interaction starts with kind of this frustration of getting into your clinic when you feel you might not have full autonomy or agency to fix it. So that's a little bit, it eats into your kind of your well-being, your psyche. You're like always in this position of being defensive. And then you go through the clinic, electronic health records, like you need to log in, log out, put in passwords, and then we don't solve for those issues till people start complaining. So after like having to log in multiple times, and because of different regulatory requirement, the screen kind of locks itself automatically after a few seconds when you're talking to the patient. So now you have to log back in. That's another pebble. Now we have badges that you could badge in that makes it easier. That's an example of an operational solution. So if there could be a badge that our clinicians can swipe instead of typing their password, then you're in the middle of the documentation, tons of clicks. Like every click to me is a pebble. I still see patients when I'm in clinic. I'm so focused on clicks. I want to minimize clicks as much as I can because I think it's just unnecessary. It slows us down. So you do all the documentation, as much of it as you can. You leave. You have more documentation that often goes into your nighttime when you're supposed to spend time with your family. And then that's just assuming if the day goes well. But imagine your medical assistant or your nurse calls out sick, or because of high staffing shortage or high turnover, there's a new MA that hasn't been fully trained, so they're not doing things the right way. Imagine like one pet peeve of mine is when I'm in clinic, I really don't like running late. And when I see the button light up that notifies me that the patient has arrived, I want that patient to be roomed as soon as possible. And if that patient is sitting there for 5 minutes, 10 minutes, 15 minutes, that's a pebble. That I just want to go and room the patient myself and say like, okay,
Yeah.
let's get this going. So those are all just examples, but there's so many more, like prior authorizations, getting rejection for treatments, having to work with different insurance companies to approve a treatment, necessary treatment for patients. So I don't know that I feel like it's starting to get me overwhelmed, but there's so many of them.
You are absolutely right, and I'm smiling. It resonates with me. I'm a practicing ER doc in an urban
Yeah,
emergency department. You're right. It's like the patient's been waiting there for 8 hours. By the time you get to them, it's like you just start well behind.
yeah,
So I appreciate what you're saying, but also for our public health practitioners, what you're really describing, you tell me if I'm wrong, but it seems like you're describing people just want to do good and help people. And when the system is just set up where that's just difficult to do, both the provider, the public health worker, and the patient, the community member, it doesn't work for anyone. And so that really resonates with me. Let's also go back and talk about really what you're describing is the answer to these pebbles is like this continuous quality improvement. Let's make the system better. That's also something that the Public Health Accreditation Board, that is what we do. It's continuous quality improvement in health departments. Talk a little bit more about some of the frameworks that you have leveraged. There's the quintuple aim, for example.
yeah,
You could kind of talk about that for a bit
yeah,
and talk about how you've applied that quality improvement lens to healthcare settings.
yeah. Um, so a couple of different things that we've used in terms of the framework for operational improvement are like the three main things. One is creating a leadership structure that really carries that through, and uh, for us in running clinics and ambulatory systems, I really wanted to make sure that our physicians and our clinicians had a voice in operations. So we
Mhm.
created this dyad leadership structure, which pairs up every operational leader with a physician or a clinician that work in a dyadic relationship to help improve operations. That might sound easy, but it's not if you're working in an environment where clinicians, the kind of in terms of financial viability, you want clinicians to spend time seeing patients. However, we realized this work is so important that we wanted to carve out a time for clinicians to really focus on operations of running of their clinics. So number one, in terms of the framework, is setting up that leadership structure that has a frontline voice. The second one was educating our team members on how we want to run operations, operational excellence, and some of it was really focused on talking about some of the basics of performance improvement, like having visual metrics that people could see what is being worked on, what are the targets, what are the gaps, and then what is the root cause analysis. In lean lingo, we call it an A3 thinking, but really figuring out like what are you trying to solve, how far are you from where you want to be, and how are you going to improve it. That requires educating the team members. So we spend a lot of time educating our team members on performance improvement. And one thing in that process that is really important is to make sure that we don't use lingo that doesn't make sense to our team members. If we're doing an A3 thinking, which is really root cause analysis, we can just call it a root cause analysis or figuring
Mhm.
out the solution. So the first one was setting up our leadership structure. The second one was educating our leadership structure. And then the third one that's really important is empowering the front line to be the change agents and respecting them and showing up as servant leaders in terms of knowing that we, like in leadership, we don't really know the answers. We might not know the answers because we're not working in the emergency room or in the urgent care at the front line. So really being respectful of our team members, to give them the tools, to partner with them to come up with the right solutions for the processes that we're trying to improve.
I really like that. As I think about how you laid it out, it's leadership, but it's also like shared governance and leadership, both the operations folks
Yeah,
and the clinical folks. It's also communication and being very clear in your communication. And as part of it, I also kind of heard it also makes me think about accountability when you're
right.
communicating, right? Communicating in simple terms. But then I love that you talked about really listening, which is so important for leadership and really in any organization.
Yeah,
Listen to the folks who are doing the work on the front lines. I think that applies across multiple fields. And so let's transition back to you wrote a book, right, about bringing back the joy in medicine. And can you share more about what can folks actually do? You talked about the operational things
yeah,
that can, but what can folks do? You're working in healthcare, public health. You're feeling a little
yeah,
bit burnt out. What can you do to kind of
yeah.
improve and bring that joy back?
Yeah, when we talk about wellness, joy, burnout, I'm always very careful because there are things that we can do as individuals to improve our wellness, our well-being, and I can talk about that. But as leaders in public health and healthcare, we need to focus on fixing those pebbles, or even more than the pebbles, there's boulders, there's big rocks that we have to overcome. So I always try to make sure that no one feels blamed, because the reason for losing the joy, feeling burnt out, is really not that there's something wrong with us individually. It's just the system is set up in a way that leads us to that. And one thing you said that resonated with me is that people in healthcare, in public health, we all want to do well. Like initially, we went into this field because we wanted to make our communities healthier. But something happens throughout that professional journey where, due to various factors, it prevents us from doing well. And then what I've seen, which brings ties in with bringing joy back, is that some of us become these renegades, like renegade do-gooders or good Samaritans, despite the systems we work in. So and it becomes like such a big surprise when a nurse or a physician goes out of their way to make sure that something happens that shows care and empathy, when we think the system is not designed for that. And I just want to tell a quick story about this because it is the motivation for what I wrote the book. So during the pandemic, my mom had a stroke. She was living alone, and with COVID, she was in her late 70s. So we were trying to keep her isolated and safe. But when we realized she had stroke, me, my brothers, my family, many nephews, nieces, we're a very family oriented kind of. My family is very tight. So everybody ran to the community hospital where we wanted to see her. Meanwhile, the neurologist called me and said that basically there was no hope. The stroke was really large. She was intubated, and they were going to extubate her that night. And basically, we only had a very limited time with her. So as we ran to the hospital, the first thing we encountered was the security guard, who said, "No one can go up, only one visitor for 24 hours." Now, in that moment, I already knew my mom didn't have 24 hours. She only had a few hours. And it was a frustrating back and forth. The charge nurse came down, and meanwhile, like, we're dealing with this trauma, this, like, the shock of my mom being healthy and talking to her a few hours earlier, and now we're hearing that she had a stroke and that she's gonna die. And during that back and forth, I talked to the hospitalist who was at the with my mom, and she said, "Don't worry, I'm going to come down." And I can't ever forget her. She came down, she made an exception, she allowed me, my brothers, to go be with my mom as they extubated her. So that is an example of doing the right thing and caring and empathy that I think brings joy back to healthcare. So now answering your question, I think we need to fix the system as leaders, but us individually, the way I think about it is focusing on three things. One is our kind of the heart. So the heart is like the why. Why did we go into healthcare? And once you see those opportunities, like I went to healthcare to alleviate suffering, and when that opportunity comes up, like it came up for that doctor who allowed me and my brothers to say goodbye to my mom, realize what is your true north and work in alignment with that why. And I think that doctor was really tired, but she did that, and I hope she realized what a big difference she did for me and my family. And when you don't do that, that's where I think moral injury happens. When you know what is the right thing to do and you act against it, that over time leads to burnout. So one of the things we can do to kind of reclaim our joy is to act in alignment with our why, which in the book I have a section called kind of the heart. And then the second part is the head, and like things, it's our limited beliefs and the thoughts that most of us have. I think I can talk about you and I being a physician. We were raised in our professional career to be competitive, to be able to graduate a college with a good degree so we could get into a medical school. Then in medical school, we wanted to do well in our rotation so we could get to our residency. And it's always this never-ending mindset of I need to do more, and a little bit of comparison, and comparison is really detrimental to our well-being. So how does it manifest as we become more kind of mature in our profession is that it starts manifesting in this colleague made a few dollars more than I did, or this one got this bonus and I didn't get that bonus, or this one got this parking and I didn't get that parking. And that just like, it's a never ending like negative thoughts that I think takes the joy away from us. So it's not an easy thing to do when we've been so focused on goals and comparison. But and I remember in my medical school being we would call it a gunner, like, oh, don't be a gunner, or like, I think we should stop being a gunner at some point because it's not sustainable. And then, so I said the three things: head, heart, and then the last one is our body. And I think as clinicians, folks in public health, folks in healthcare, and there's a lot of other industries, we tend to neglect our well-being, our physical well-being. So how does it manifest? There have been days, and I'm also a work in progress. I'm not perfect, but there are days when I'm back to back meetings, and I realize I have not had any water. I have not used the bathroom, and I've been sitting. And when I stand up, I feel like my whole body is like so tight. Or we neglect our sleep, especially in emergency department, like that constant shifting of like night shift and day shift. So how do we make time and prioritize our well-being by focusing on our sleep, our nutrition, our exercise, kind of our joy in creative endeavors, which is something I've started doing more recently, about exploring like poetry or comedy, and also prioritizing our family, making sure that we spend time with our family. That was a really long answer. Thank you for hanging in there.
No, that was great. I love it. Your heart, your head, your body. And then, but there's also what I'm hearing is a connection between them. If you are
Yeah.
taking care of your body and sleeping, you can actually bring your heart to work, right? You can have more empathy. And I really also something that's really important that you noted is remembering that we're here to serve people. As hard as
Yeah.
it gets, we're here for people. So
Right.
remembering that humanity is so
Yeah.
important. Patients are not just another box to check off on your
Yeah.
list. They're not, one of 50. I'm thinking about my whiteboard, my trackboard in the ER. They're not just numbers and names with triage,
Yeah.
ESIs on them, right? They're real people who are there scared. Their families are there. And so that's really, really important. So thank you. Thank you so much for highlighting that.
Yeah.
So let's talk a bit about the upcoming folks, professionals who are looking to go into healthcare or public health. Last year, the number of medical students in the U.S. reached an all-time high, almost 100,000 medical students. We also know that just recent events have actually inspired people to want to go into these fields. What is the best piece of advice you would give to someone who is, they're on that track? They've got to get that good test score, that MCAT. They got to get into a good residency. Maybe they don't want to be a gunner, maybe they are. I don't know. But what advice would you give to someone who's currently on that trajectory to becoming a physician or public health leader so that they can be successful?
Yeah. I think first thing I wanted to say was that like keep on going. Like it's to me, I can't even imagine any other profession. It's the
Yeah.
best field. It's such an honor and privilege to be a physician, and you could pivot your career in so many different directions, like I've done. I did primary care, then I did HIV, then I did palliative care, then I went into leadership, and it it allows for a very kind of exciting career path. So keep on going, stay strong. It's not easy. Uh, the advice I have is an advice that I would give myself, and I'm not sure if it's the right advice or the wrong advice, but if I personally was looking at my kind of 20-year-old self who was motivated to go into medical school, I would tell that person, don't like miss the journey. Enjoy like everything that's happening in your undergraduate year in medical school. It's really such a precious time, and when you're always focused on this next step, getting your MCAT and getting into medical school, I feel like I missed out a lot throughout that journey because it came from a place of really desperation for me. I am the first person who's a physician in my family. I immigrated to the United States when I was 19, and I could barely speak English. So for me, that was such an unachievable goal that I thought the only way to get there would be to work hard and to not have any fun. So I was like working, I was trying to get A's in all my classes, um, and then I was just working to financially kind of support myself. So it came from a place of desperation. And if I go back, I would say, um, I wish I had a little bit more fun throughout that journey, but also maybe if I did, I wouldn't be where I am now. So uh, anyway, it's a non-advice advice.
No, I really appreciate what you said. And you also bring up something that I think is really important is those who don't come into this with privilege or who are underserved or immigrants or whatever it may be, there's an additional burden and pressure
Yeah,
that is upon folks in those situations. And I think it matters. I think it's important to talk about as well. It's again, remember your body as you are
yeah,
going experiences and certainly I remember my days in medical school. I had a lot of fun. We were studying hard, but it was great building those friendships and relationships
yeah.
throughout the journey. um, so we'd love to get another piece of advice from you, and something that I ask all of our guests, for folks who are currently in leadership operational roles or public health leadership roles. Is there one kind of actionable tip that they can implement now? Is there a practical resource? What should they be doing now as they're striving to improve the health of the communities that they serve, but also to find joy in their work.
Yeah, the simplest thing that comes to mind is taking a quick mental break in between meetings or in between patients. I feel like the sense of rushing always leads me to act in a way that's not in alignment with my values, with my goals, and then I end up regretting it. So I wrote about this in my book. When I'm in clinic and seeing patients, I've made this habit that whenever I'm putting my hand on the door handle, before I enter the room, I quickly it takes only a few seconds. I take a deep breath. I'm like, be the best doctor for the patient on the other side of this door. Like, let go of everything. And then I walk into that room. And I've now made a habit of doing the same thing before I click on a Zoom, kind of join the meeting, or on Teams, or if I'm even walking into a meeting, I set intention for that meeting, because it's so easy to run from one meeting, one call, one kind of virtual meeting to another meeting. And we are always feeling rushed and not really acting in a way that's in alignment with what we hope to achieve. So I do that before the meeting, but also early in the morning. And there's two things I do. One is every week on Sunday, I look at my calendar and I try to say, like, what do I want to achieve every day? Like, okay, on Monday, I want to achieve, and I limit it to three things, just three things. Like, that's my intention for Monday. But also Monday morning, I look at my whole calendar for Monday, and intentionally, I'm like, oh, this meeting is a crucial conversation. I want to show up with care. This meeting is a finance meeting. I really want to make sure I review the budget, know the gap, know why we have variations. Like, that's the purpose. So the advice is just take that few seconds to set an intention to show up the way you intend to show up.
I love that. I'm sure that resonates with our listeners. Take a moment, set an intention. I think that's
Yeah.
something very simple that we can all do more of.
Yeah.
And so, finally, again, so thrilled to have you as a guest. I hear that you have a knack for stand-up comedy. So, if you would, could you share with us, like, give us your like best corny, I don't
Uh,
know, joke, healthcare joke. Give us something.
Yeah, I'm not sure if it's the best, but it ties in with our conversation here, being a physician and also being an administrator. So I
Yeah.
feel like when I'm in clinic, sometimes I spend so much time writing a prior authorization for my patients, and then the next day, as an administrator, I deny that prior authorization. So, uh,
Yep. Yep. That's about it. It's the irony of healthcare. I love it. Well, Dr. Alen Voskanian, it is so great to have had a conversation with you today. Thank you for joining our show.
Thank you so much. I really enjoyed it. I hope there were some nuggets that your audience would found beneficial.
I know they did. Thank you.
Thank you.